Just a second. Hello to everybody. I think everything is clear. My name is Mihai Juncar. I'm an oral and maxillofacial surgeon. And the topic of today is approaches of maxillary bone deficiency, clinical and therapeutical possibilities. Well, a short briefing at the beginning. I don't know exactly the level of my colleagues that I'm speaking with. So we'll have a little bit concept. Why do we have bone deficiency? And we will analyze some cases in some defects of bone in the maxillary, from small cases, simple cases, to iliac crest reconstruction. I don't know exactly what type of patients do you have in your everyday practice, but from my point of view, a lot of patients I have are referred to me by other colleagues. So situation like this in these pictures, I encounter pretty often. As you can see here in this picture, it's a patient who was referred to me by a colleague of mine, and you can see that we have a lot of bone deficiency here in the upper jaw. Plus, we have an impacted canine here, and we have also some post-extractional socket, pretty young post-extractional socket. It was only 2 weeks old on this region. In the other image, you can see a different type of case, also which was referred to me by a colleague of mine. And you can see here that you have a huge bone deficiency. These patients, she did have 5 implants, only 2 of them survived, and you can see here pretty clear why those implants have such a low survival rate. You can see that we have a lot of bone deficiency also in the frontal region and also in the lateral region. So, what are our options when we have a patient like this? Well, actually, we have 2 fundamental options. First is to have a complete denture, but not to forget, those patients came to us because they don't want a complete denture. Those patients want from us implant restoration, implant support denture, to have fixed teeth or to have as much as fixed the teeth it can be. So we have to do an implant reconstruction. But in those situations, we have a problem. What is our problem? The problem is that we don't have enough bone. So, the first question, how much bone is needed to insert a dental implant? Well, this is a continuous changing answer for this question, because over the time appeared a multiple implant system, a multiple concept. We have short implants, we have zygoma implants, narrow implants, and so on. But first of all, we have to evaluate the bone quality and especially the bone quantity. We have 4 variables according to Misch. One is the height of the bone, the other is the width of the bone, the other is the length and the angulation of the bone. Well, the height of the bone is something that all of us are looking at the beginning, because if you have an X-ray like this one here, you can see the height of the bone. You cannot see the depth or the length or angulation of the bone, but you can see the height of the bone. How can we measure that? I prefer usually to do a CBCT in order to prepare my cases, as you can see here. And standard, you measure the height of the bone from the crestal and dental ridge to the opposite landmark. In this case, it's the nasal floor cavity, or if you can see here, we are speaking about the maxillary sinus. Also, we have to analyze the bone width. This, as a general rule, is to provide more than 1 millimeter of bone on each side of the implant. That means that we must have a good blood supply in order to have a healthy and a stable bone around an implant. So the problem is especially in the maxillary group, in the frontal maxillary group, where the vestibular and cortical is very thin. As you can see in this picture, we have less than 1 millimeter, and I'm sure that all of you have seen this in your daily practice. In the frontal region, we have a very thin cortical, or in some cases, no cortical. Of course, we have to evaluate the bone length. This is the mesiodistal length. Standard, we must have 1.5 millimeter from adjacent tooth and 3 millimeter from the adjacent implants. As you can see here, this is a particular case that I encountered. You can see we have 11.7 millimeters here. This is a problem. What can we do here? We have actually 2 options in this situation. First option is to do an orthodontical treatment in order to increase, for example, this space. Most of the patients, from my experience, will not like this situation. Why? Because they don't want to wait so much, they don't want to use brackets and stuff like this. So the other options that we have in this situation is to use special type of implants, like narrow implants, which are more and more often on the market. Also, we have to evaluate the bone angle. This is a problem, especially in the frontal maxillary region. As you can see, initially, he represents the natural tooth root trajectory, but over the time, this angle tends to change because this is the region when we lose the most of the bone. It's the same case here. You can see in the frontal region, we have a 37-degree angle. This is a high angle. An ideal base, we should have a perpendicular angle to the occlusal plane. Here we have 37. This is the premolar region. You can see it's still a high angle, tends to be acceptable already, 21 degrees, but when you go into the lateral region, you can see that the angle is only 4.01 degrees. This is the good situation. So, what are the causes of bone deficiency? According to Carl Misch, and everybody knows, the extraction goes with lack of stimulation to the residual bone. In the first year, we lose about 25% in decrease in height and 4 millimeter in width and 4 millimeter in height. And we have to remember the fact that bone loss continues during the life. Especially, bone loss is significant in the long-term edentulous patients, as you can see here. Also, from my current practice, I saw that it's very important the metabolical age of each patient. For instance, if you have a younger patient and you make an extraction, you ask him, okay, what do you intend to do after you make that extraction? And he will say, okay, I don't know. I'm thinking maybe I will put an implant. I don't know. You should tell to that patient that, especially if that patient is young, that he have higher chances to lose a lot of bone than an older patient because the metabolism is more active for those type of patients. Also, there are some local factors that can increase the bone deficiency. The periodontal disease, for instance, here, look at this picture, look at this X-ray. You can see here that this X-ray, this is the date of the birth of the patient. It's a patient who was born in 1979. And here is the situation in 2017. You can see that we have a lot of bone deficiency in the upper jaw and also in the lower jaw, because in the history of this patient, it was an aggressive periodontal disease. The patient lose all her teeth pretty young. After this, it was a total denture, and now she came to me with this situation because also the total denture was not able and suitable for her anymore. Also, it can be some other particular situation, and you can see here, this is another young patient, around 13 years old. You can see a large cyst in the upper jaw. Here the cyst it's an inflammatory cyst with a dental origin, and you can see that the cyst here go into the vestibular region. Here is the limit and invaded the maxillary sinus. And also from this picture, you can see that the cyst invaded also the nasal cavity and also almost the floor of the orbit here. So in this situation, we will have large bone defects. But first of all, let's see a little bit which divisions of bone do we have, which is the possibilities that we have. Carl Misch established 4 classes. Of course, these classes have some subdivisional classes. Class A and Class B is something that everybody likes. I like Class A and Class B. About Class C and Class D, well, this is with a little bit of mixed feeling. You know, Class C, you can see low height, low width, not a good angulation, very high crown space in both of them. So I have mixed feelings. Depends if you like something that will not let you sleep in night or if you like the challenges. But usually I do like the challenges. And I think these are the most interesting type of available bone that we can encounter in our career. So what are we doing when we don't have enough bone? Now, it's a correct question. We have 2 options. First is to have bone reconstruction. The other one is to find alternatives to bone reconstruction procedures like special implants. In my experience, usually I do bone reconstruction. I'm at the beginning with special implants. I don't have enough experience, and I don't want to talk very much about that because I don't have the necessary background. I searched on the literature, but not enough in order to make a correct opinion. So usually I do bone reconstruction. Okay, if we decide to do bone reconstruction, which type of bone reconstruction, when can we do this bone reconstruction? What type of the bone reconstruction is the most suitable for each case? Well, that depends on many factors, actually. Well, for instance, look at this case. This is a minor defect from my point of view. You can see here that we have about 1 cubic centimeter of bone. It's an inflammatory process, as you can see here. Okay, you don't have buccal cortical, and you can see that also both of the teeth are affected by this cyst. This is a situation pretty often seen in our daily practice, but it can be also this situation. Look here in this image, you can see we have a lot of bone loss in the frontal region, and actually in the lateral region, the bone loss is a little bit, it's a less bone loss than in the frontal region. You can see here the bone height is about 12 millimeters, but we have a very thin bone, about 1.4, 1.8, and 3 millimeters. That will be challenging because in this particular case, the person who came with me with this situation, she wanted to have a full mouth recovery with dental implants, with a fixed overdenture. And this can be a pretty big challenge for you and also for us, for all of us. So how can we reconstruct the bone? Well, actually, there are a lot of situations, a lot of techniques to reconstruct. I not have enough time and I don't have enough knowledge to be able to talk about all of this. I will select only the techniques that I use most often and that I have more experience with them. So I use usually guided bone regeneration, online block bone graft, ridge splitting, edge expansion, and of course the maxillary sinus surgery. Those are the techniques that I use most often, and I could see the results over the time. So what type of graft do we should choose? Well, that depends also. We have autolog graft, allograft, xenograft, alloplast material. Depends. The type of the graft depends very much on the type of the reconstruction that we have to make. For instance, in my opinion, I will not use alloplast material to put an online graft. Alloplast material by themselves. I will have a mixture between alloplast material and autolog graft. If you look into the literature, you can see that all of these materials have a similar stability. You can see here that we have 1.5 to 0.2 millimeter in decrease of bone. 1.8 is not a very big difference, but it's a very big difference if you use these materials in situations which are not suitable for them. For instance, for sinus lift, I will not have a problem to use alloplast or xenograft or whatever you want. But as I told you before, for online graft, I will have a problem not to use autolog graft. Well, even today, the autolog graft, as you may know, is considered like a gold standard for choosing a graft procedure. But also this one have some disadvantages, and we will talk about that later. So we have different approaches for reconstruction. These different approaches, especially when we are speaking about topography, where the bone defect is. Can be the bone defect in premaxilla, the bone defect in the posterior bone defect, it can be, or both premaxilla and this posterior bone deficiency. So we have to choose and improve our technique in order to be able to solve as much as possible from those. So for the beginning, some simple cases in the premaxilla bone deficiency. Usually there are two situations. If we have bone deficiency with a tooth present or bone deficiency. As you can see here in this picture, it's in this image, it's a different situation. Here we have an incisor and actually no bone around him, only inflammation tissue. You can see here, and after we make the extraction, actually we will have only this part of the bone. This will remain. But here, it's an old extraction site. So you can see the typical atrophy on the frontal region, especially on the vestibular side, as here is the same situation as here. So what do the patients want? Bone deficiency, when the tooth is present, the patient have a different approach compared with a patient who has a tooth absent for a long period of time. Usually, I saw from my experience that the patients who have the tooth present, they will want something very quick, not very expensive, with predictable results, and if it's possible to be done yesterday. So most of the patient will want a quick restoration for the aesthetic zone. So what are our options? Well, first could be spontaneous healing, but this could do to a large bone defect. Another option it will be immediate implant placement. That means that you put an implant, filling material on any gaps, but this one has some limited indication, and we'll talk about this a little bit later. Another situation is socket preservation. A temporary prosthetic solution must be found in this situation, and another situation is to have an early implant placement, about 6 to 8 weeks. But this is a problem when we have large defects, because in 6 to 8 weeks is very probably not to be able to have enough bone there to put an implant and to have a primer stability in that region. So another option is to have delay implant placement. Well, in this case, we'll need some prosthodontic, temporary prosthodontic to be the reconstruction there, and we'll need most likely further reconstruction if we do not make at least socket preservation in that area. So we have to decide what to do. So the decision making process have some steps. The most important thing from my point of view is the anatomical factors. Periodontal biology, I prefer thick periodontal, gingival beard type, position of buccal gingival margin. In this case, in many cases, we don't have a stable position because it's only inflammation in that region. Alveolar bone crest height in the interproximal area and buccal area. This is a very important factor because this factor will determine the level of the bone that we will get on that region. Also, the buccal alveolar bone wall thickness and height, this is another important factor, and this factor usually is absent, because especially when you have long-term inflammation in that area, you will not have a buccal alveolar bone. And of course, you have to do a 3D planning position for the implant and to choose the implant, the right type of implant and the right characteristics. For instance, in this case, you can see here, we have an incisor, is the same case, and you can see here that we don't have buccal weight, we have a good bone height. Here we have a bone deficiency in this region, as far as you can see. So what are we doing? Planning to put an implant there, or 2 implants, because it's about both of those two. So in this case, this is the position of the future implant. The choice of implant. Well, we have many types of implants, different types of implants. Usually, in the frontal region, it's normal to choose bone level implants. Why? Because you are looking for a good aesthetic results. Tissue level implants are very good implants, but not from the frontal region. At the beginning of my work, I was taught to have a larger implant as possible. You know, you have whiter teeth, you put a whiter implant. That's wrong, because over the time I have problems. The implants transpire through the mucosa, and it was not a good aesthetic results. Another problem was that the bone around the implant was not stable. Why? Because usually the bone is very thin, it's very thin, and if the bone is very thin, you don't have good vascularization in that region. So always remember, you are not doing mechanic, you are working with a biological system. And in order to function well, a biological system, and especially a bone or a mucosa, but especially the bone, it should have good vascularization. So I choose usually the smallest diameter implant possible that will not compromise the biomechanical requirements of the tooth. Usually these 2 types of implants, 3.7 or 4 millimeters, because in those type of implants, I already have a good primer stability. The resistance of the implants is okay, but also I have a lot sufficient space around the implants in order to permit the bone to heal properly. What type of filling material? Well, this is not very important. Usually I prefer bovine bone grafts, but you can choose whatever you want. And of course, you need to choose a membrane. Usually I choose collagen membrane and pericardial membrane. The principle you can see in this diagram. Here is the situation. You have the tooth and the vestibular plate is very short, and after this we make the extraction. If we do this extraction, you will see here that the healing will be like that. We'll have a bone deficiency in this region. So it's important to put an implant like here. These are the adjacent teeth, but the most important is to analyze the bone in this region or in this region. as you can see, because this bone from those regions will be able to give you the level of the next bone. And another thing that you should keep in mind is the fact that here you have a very thin bone, about 1-2 millimeters usually. So it's most likely to lose this part of the bone here because of the lack of vascularization. So I recommend to put the implant a little bit under this level with 1 or 2 millimeters. So which are the treatment steps? Well, the first is the extraction. This is another case, a patient of mine. You can see here a canine. We can see here that the bone level is the same at all of the teeth. So first is to make the extraction. Then it's very important to remove all the pathological tissue. Some of these patients had in the past different type of abscess, maybe a fistula, stuff like this. So everything should be clean. Everything inflammatory from that region should be clean. Then put the implant, and after that apply the filling material, the membrane, and then put the stitches or healing cap or temporary crown or whatever you want to do. This is the planning of the implant position for that canine, and you can see here the situation. The same case, you can see on the palatinal side, we have a lot of bone. Usually I go with the implant a little bit more palatinal here to have a good contact with the residual bone from this region. As you can see here, I modify also the axis of the implant a little bit. I put it more into the palatinal zone, and I can see here, you see, here we have 1.7 millimeter of bone, a little thin, but here the bone quantity increase, and this is the situation. So, after you make the extraction, clean everything around the implant. You can see here a little bit of connective tissue, then put the filling material and then the membrane. Usually I use only one pin, as you can see in this picture here, it's only one pin, and after this put the stitches. Why use only one pin? Because in the future I will have to remove that pin. It's not compulsory, but it is better not to let a foreign body there. So if we will have more than one pins, that will be necessary to have a little bit more work after that and a little bit more traumatic for the patients. Another situation, as you can see here, it's about these two incisors, lateral and central incisors. And this is the situation of the central incisor. We can see here a little bit of cortical, very, very thin bone, no bone here in the apical region, the position of the reconstruction, and here you can see is the situation of the lateral incisor. The same, the absence of bone here and the inflammatory process. Actually, after we remove the teeth, this will be the bone that will remain, only this part of the bone. So what I have done there? Well, I removed the teeth, and after this I put two implants. A little bit longer implants here and here. After this, put the filling of the grafting material and put the stitches. In this particular case, I want to have a temporary fixed reconstruction with the support of the implants. So I made immediate loading, but not just immediately, about 10 days, because this is the situation 10 days after I remove the teeth, put the implants, make the reconstruction, and this is the clinical situation 10 days after that. At 7 days, usually I remove the stitches in situation like this, because from my experience, the patients avoid to clean that region. If I have stitches there, the patient avoid to clean that region. A lot of food will remain there, and this food will stimulate to have an inflammation there, and the healing process will not be the same. That's why I removed the stitches about 7 days, even 6 days in some cases. But what if we have old extraction bone deficiency? What options we have? Well, we have two options. We have autolograft and bone splitting. I personally prefer the second one, and I will explain why. But also the autolograft can be a good choice. The principle of autolograft is this. You have a thin bone, you take a graft from nowhere, doesn't matter too much. Well, actually matters, but it's not a crucial importance right now from where. Fix the graft on the bone and then wait for about 6 months in order to be able to put an implant here. Here we have a problem. The problem is that when you put an implant, if you are not working very carefully, this in this region, you will have some forces. What these forces will do? These forces will tend to split the graft here and here. And this is something that I like about these implants, the fact that I have a conical part here. That means that the tension comparing with the cylindrical part, sorry, that means that the tension comparing with a conical implant will not increase suddenly. Is the cylindrical part, and here is the conical part, and the cylindrical part is here. That means the tension will be a little bit less than from a conical implant. And when you choose an implant to put in this situation, please, I recommend you to choose an implant that is not very aggressive. The threat of the implant are not very aggressive. You can see in this picture, here is a case who was referred to me by a colleague of mine, and the patient have a problem with this region because it's an old extraction site and he wanted a reconstruction. This is an old case of mine. I have done this case, I think, 8 years ago or 9 years ago. So you can see here is the defect. Then I put a graft here. I fix the graft with one screw, then a little bit of filling material around. This is a collagen membrane that I put over the graft. And as you can see here, this is the control X-ray after I make the graft here. You can see the screw, and also you can see here the place from where I took the graft. This is the situation 6 months later. It has been a temporary crown here, an extension from this canine, and this is control X-ray almost 1 year after the grafting. But what if you have a different situation? What if you have a situation like this one? You can see here, you have thin bone here, lack of bone in the lateral region, lack of bone in this lateral region, and this is the situation in the frontal area. And I'm start working and looking for the bone. Where is the bone? Nowhere. Those are the best situation that I could find. The highest quantity of the bone, 9 millimeters in height, 2 millimeters in thickness, 10 millimeters, 2.9, 10 millimeters, almost 11, 1.4. So in this case, I prefer to do something like this, to have a bone split. Why to have a bone split? Because I do also a lot of trauma. And I think I see the patients with trauma with old fractures, mandible, maxillary fracture, doesn't matter. In some cases, they heal without treatment because not all the patients go to the doctor to see what their problem is. And the principle here is very safe from my point of view because you have here the situation that the bone is thin, and you split it in two in order to have two parts of the same bone. And the natural thing that the human body will do, it will try to unite those two parts. So if you make this split and then put an implant there, the natural thing that the human body will do, it will be to make connective tissue, mineralized connective tissue, and then to start working, and you will have bone in this region. I think it's very, very helpful as a technique, this technique. But you should take care of one little bit of a problem here. Here, all of the time, you will have very, very thin bone with a very poor vascularization. So we have, when you choose the implants, we should choose very carefully and think what type of reconstruction do we want to do. Because we have one option to put the implant 1 or 2 millimeters deeper. If we can do that according to the quantity of or the height actually of the bone. The other situation is to put an implant, a tissue level implant here. But in this case, we will not be able to use only removable overdenture because otherwise we'll have aesthetic complication. As you can see here, usually I do a crestal incision, expose the bone, like you see here, elevate the flap, usually from only the vestibular side. I use a piezotome and then put the implant. Sorry, the pictures in this situation are not so good. Another observation. Here, the crest is very thin. When you use a piezotome or other type of instruments to split the bone, the tendency will be to lose control of the instrument. So I can advise you to use a bore and to take about 1 millimeter in height in order to have a plateau here, to be able to make that split. And this is the situation after the split. You can see here, the bone is thin, those are tissue level, because in this situation, we choose for a removable overdenture. And this is the situation after we reconstruct after we put the overdenture and we reconstruct put the overdenture and make the reconstruction in this area. So, what about if you have posterior bone deficiency? We can have bone graft. The sinus is the major problem there. We can have bone graft, we can avoid the sinus, or we can use short implant in that situation. So look at this case. It's a very nice case. Everything is wrong here. Occlusion is wrong. Retraction. The sinus is inflammation here. You can see here is the situation on the left side. You can see here no bone, inflammation everywhere we look, and which is the first step that we should take here. Well, from my point of view, the best and the most important step is to clean everything, to remove all the inflammation in that region. After you remove the inflammation in that region, you can do whatever you want. In this case, I make a sinus lift. Usually I do approach of the lateral sinus lift, and in most of the cases, I put the implants in the same time as the when I do the sinus lift. And I like this, especially in conical implants, because if you have 2 millimeters of bone, you must have primer stability. In order to get primer stability, this part of the implant is very important, not to be very aggressive, but this part will give you the primer stability, and the contact with the bone should be as much as possible in order to have that primary stability. And this is the situation, the control after we put the implants in frontal region, and this is the overdenture. Another option that we have is to avoid the maxillary sinus. You should choose very carefully this situation. In this case, you can see here not enough bone, and especially here is not enough bone. In the frontal region, we have acceptable bone, 6.5 millimeters, 5 millimeters, 4, and so on. So, what can we do here? We can use all-on-4 or all-on-6 system. Why? A disadvantage of this is that usually we'll have a shortened arch. We should think what the patients have on the mandible side. If the patients on the mandible sides have almost all of the tooth, he or she will feel that the molars are missing. And also, when you choose to put 4 or 6 implants, also you have to choose according to the biting force of the patients. The male patients usually will have a higher biting force, so we'll put 6 implants. In the female patients, the biting force is not so high, and especially if a removable denture on the mandible, for example, the biting force will be not so powerful. So in this case, I choose 4 implants. As you can see, the multi-unit, the implants, the concept is to use 2 straight implants in front and to angulate it, position it implant into the lateral part in order, as you can see here, to avoid the maxillary sinus. Then we have made temporary reconstruction, and this is the final situation. And as you can see, we have only premolars, but in this case, it was something suitable. Another thing that we can do is to use short implant. I am not so experienced with the short implant. I'm at the beginning with them, but I find the concept more attractive. Think a little bit. If you have a patient that came into your practice and you said, okay, we have 2 options. First option is to make a sinus lift and to put a graft there. And the other option is to put, let's say, 2 short implants there. What do you think that the patient will choose? Usually the patient will choose to have 2 implants. And the concept and the choice is correct. Why? Because you don't go into the sinus. It's much more easier, it's not so expensive, and studies from the literature show that the concept of the short implant works. You have a failure rate about 5% higher than standard implants. It's a small difference between them. The idea is to have a short implant, in this case, a little bit more aggressive, because in the lateral region, the bone doesn't have the same density as in the frontal or in the mandibular region. So the short implant in these cases are a little bit more aggressive in order to compact and have a better primer stability. And like you see here in this case, we have about 7 millimeters in this situation, inflammation of the sinus, very, very poor situation here. We remove everything, and in the lateral, I use short implants. I'm still waiting for the results. But what if we have problems in both frontal region and in posterior region? Look at this case. I already showed you this picture here. So we have bone deficiency in the maxillary region, in frontal region, and we have also an impacted canine here. You can see it's just between the nose, sinus, and the cheek region. When I start I try to find the bone. Where is the bone? So I start measuring. You can see here we have 2.3 millimeters in height, 2.26 millimeters in depth. This is the nasal cavity. This is the maxillary sinus. This is the clinical case. The best situation I found it around here, it was the situation in these pictures. 10 millimeters of bone, almost 4 millimeters in thickness of the bone. And this is in the lateral side, into the left lateral side. This was the best situation that I could find there. It was 5 millimeters in height and almost 2 millimeters in thickness. So I start trying for a solution. I start thinking to a solution. I speak with the patient. I ask him what he wants. And he said, I don't care what you are doing, but I want to have fixed teeth on the upper jaw. I don't want to have a complete denture. I already have it and I hate it. I don't want it. So we started to look for the bone, and we find in the iliac crest. You can see here the mark of the iliac crest. Make an incision into the skin, subcutaneous skin, and then looking for the iliac crest here. Expose of the iliac crest, as you can see here. Then, under saline solution irrigation with a burr, we took some bone blocks. In totally, we need about 10 centimeters of bone from the iliac crest. As you can see here, the situation, the bone block. After you remove the block, you have usually this situation. As you can see here, it's very important to have a good control of the bleeding. So the next step will be to assure the hemostasis of this. Usually we use electrocautery. Also the anesthetist can help you a little bit by lowering the blood pressure in order to work more comfortable. And then close the wound at least in 3 layers. As you can see here, tissue, subcutaneous, fascial, and cutanate layers. After this, you should prepare the receiving side, the maxilla, as you can see here, a crestal incision, elevate the flaps on both palatinal and vestibular side. And here we have exposed, it's not very clear, the canine, and we removed the canine from this part. After this, the bone block, as you can see here, are kept in saline solution, and usually they look like that. They have connective tissue, they have muscle tissue on those. It's very important to remove all these connective tissue. Why it's important to remove all this connective tissue? Because you don't want it to be there. There you want to have bone, not connective tissue. So the bone should look like that. As you can see, the cortical and the sponge is here. After that, I check the situation of the graft. Usually the cortical, I put it on the vestibular side because it works, it helps me keeping the soft tissue apart from the bone that I want to grow in that region. Before I fix the graft here, I make a hole in the graft, I put a screw, and after I put the screw, I fix the graft on the maxillary. Remember that I have 2 or 3 millimeters of bone. So in this case, it's very important not to use excessive forces, because if you are working too hard, too powerful, you will break the bone that have to receive the graft. Of course, that you cannot put one continuous graft. You have to split the graft in multiple blocks, fix every blocks, and this gap shouldn't remain like that. You should fill this gap with autolog graft or with other type of graft, doesn't matter. But after that, you should put a membrane, make an incision to the periosteum in order to be able to advance the flap. And this is the situation of the patients 24 hours after the surgery. You can see there is a little bit of fibrin here. You have to clean it up. And this is the situation before and this is the situation after the iliac bone graft. As you can see here, this is the situation with a screw. You can see we have more than 8 millimeter in thickness and only more than 10 millimeters in height. So from 2 millimeters, 3 millimeters to have 1 centimeter, well, I think it's a pretty good result. The difference time within this was about 5 months from here to here. After that, I put 16 implants, and this is the final result with a fixed over dentures, and this is the situation. But this type of technique has some disadvantages that most of the patients will not like. One of that is that you must have a donor site in the hip. That means that you have a supplementary surgery. The other thing is that you need two teams. When I do iliac grafts, one of my colleagues collect the graft, I do the reconstruction usually. This is the type. From some other times, I collect the iliac graft, and another of my colleagues have to do the reconstruction. Another disadvantage is that you cannot put immediate implant in the iliac graft. You have to wait a lot of time to be healed, and after that, you can do reconstruction with the implants and with some prosthetics. So I'm looking for an alternative, and I find this alternative. Unfortunately, or for our best, there are only a few companies in the world who have the knowledge and the possibility to do this, zygoma implants. I don't have so much experience with them. I'm starting to using the concept, but the major advantage that I can see from this concept is that you don't have to open another place in order to have a reconstruction. But I'm starting to using that. I'm training with that, so I think it will be a different webinar about this type of implants, and I'm sure that webinar will be very helpful for all of us. Thank you very much. I'm speaking from Oradea, the Art Nouveau capital of Romania, in northwest of Romania. Thank you very much for your time, and I'm looking to see your questions. Hello. Well, yes. Okay, I see there are a few questions here. So, start answering. The first questions is how much iliac crest bone block resorption? Well, this is a tricky subject. Usually in the literature, the reports are about 2-3 millimeters. If you have, for instance, a reconstruction of 1 centimeter. But unfortunately, this is pretty difficult to predict how much of the graft will be resorbed after you put the graft, and that's why I'm looking to find something more predictable like zygoma implant or other type of reconstruction. But usually the graft in the first 6 months will be resorbed about 1 to 2 millimeters. Okay, another question is about pterygoid implants. The pterygoid implants, it's a possibility. They have some disadvantages. I don't use them very much. I have 1 or 2 cases. I'm not very suitable to give you a good answer about that, but I have a little bit of concern, especially when the doctor do not have a lot of experience, because the complication, you know, I do also infection, I treat also infection, and I did have some cases with necrotizing fasciitis started from the pterygoid region. Of course, the started was from the odontogenic origin, but it's really a severe complication, and especially if the operator do not have a lot of experience with them, I will recommend to stay a little bit more calm with the pterygoid implants, but there can be also a situation. So let's see another question. Just a second. What all usually problems with the short implant in the maxilla? Well, the problem with the short implant, but this will be a topic, I think, of another question. The problem with the short implant is that it can have a resorption rate greater than normal implants. But I think that they are worth it because avoid you to have different procedure to interfere with. Avoid you to have more and more procedure to do. And I think also the patient will accept them much more easier. Thank you very much. Yes, I use collagen membrane on the bone graft. I show in this lecture a case when I use collagen membrane on a block bone graft. The problem with the collagen membrane is the fact that usually they disappear a little bit too quickly. So yes, there is a possibility to use collagen membrane. It's not my first choice, but I don't think it's a bad choice. Well, what possibilities to for the implant to slip into the sinus, especially at the first molar maxillary tooth? Yes, this is a possibility. That's why you should check the primer stability. If you have a good primer stability when you put the implant, the chances are pretty low. Depends very much on the technique. Usually I recommend, and also when I'm working, I'm trying to manage the tissue as much as possible. I elevate the sinus membrane only the necessary region, not too much. And it's very important not to be very traumatic with that. But it's an accident that can happen, and yeah, it can be a problem, but it's an accident with a pretty low incidence rate. Just a second. Well, in these cases, I didn't use zygoma implants. I make the reconstruction, but I am looking for a situation or for a possibility to avoid the secondary secondary place to harvest the bone. That's why I'm looking for situation not to be too traumatic, too invasive for that patient. This is the idea. The idea is to have less surgery and to have not less surgery, to have a better recuperation for the patient. That's why I'm looking for using zygoma implants. I'm not sure that I understand this question. Please give some experience, give implants and artificial bone and collagen membrane replacement in medically compromised patients. Depends what do you mean by medically compromised patients. If you mean that do you have oncologic patients, this is very weird question, but depends on the pathology and depends on the situation of each patient. Usually, there are only a few pathology that limited the use of implants or artificial bone, and these pathology are not like everybody says diabetes and stuff like this. I have done some research on those, and the integration and the success rate is not different from any other patients. Usually, when you have medication that change the bone metabolism, that will be a problem. Or if you have a region with radiotherapy, for instance, and I find this situation pretty often on my oncological patients, and but of course those are particular situations. But otherwise, you can use it in almost not in all of the pathological conditions, but in a lot of those type of conditions. Well, titanium mesh bridge augmentation, I think as a concept is very good. I don't use it very much for two reasons. Depends if you use it on the maxillary or on the mandible. When you use this in the maxillary, I think the success rate is higher because you have different vascularization there, different type of bone is better. A major disadvantage for this titanium mesh is the fact that the mesh is exposed in oral cavity pretty often. And if you have the mesh exposed in oral cavity, all the reconstruction is compromised. The second problem that I have with this type of augmentation is the fact that you have to re-enter to remove the mesh. So you need a second surgical intervention. But it is a situation that can be very helpful and is very logical. Thank you very much. Well, it's very difficult on this. Please, all of the techniques, there are a lot of techniques to bone reconstruction. I cannot and I will never say that one technique is the best and another technique is the worst. Every technique has its own advantages and his own disadvantages. It can be a useful technique, of course. So I suppose those are all the questions.